61-year-old male. He has HCC with very, very segmental tumor in vein, as you can see here. So he has a 3-centimeter HCC in segment 2/3 with a small little invasion on contrast ultrasound into the adjacent portal vein. What are our thoughts for segmental tumor in vein? He has portal hypertension, has the tips, so probably not surgery, but you'll come into play in a second, don't worry.
Yeah. Not surgery. I'll wait for my turn. You guys go ahead.
So actually, let me ask you, would they be a transplant candidate eventually? Or what's the policy in San Diego in terms of tumor in vein? Because this is a constant point of contention and discussion in our group. Once you have PVT, are you ever a transplant candidate or not?
So again, I think this is one of those situations where the dogma is evolving, right? It used to be that was just a flat no. Now I think it's more like it depends. Where is that tumor in vein occurring, and how does it respond to treatment? Again, do you see a durable response? I still think it wouldn't qualify for the standard MELD exception. You would have to, apply for an exception if you saw a good durable response to treatment, but it isn't a right out of the gates a hard no, as I think it had been for the longest.
Yeah, I agree with that. All those sentiments that we used to say hard no. Again, that was the dogma. Now we're segmental, we're entertaining, and especially now that you have tear, you have other options on the table, we might think about it, but you have to show the test of time that you're not going to progress, because this is clearly a much more aggressive biology. So it's not an absolute anymore.
And so now it becomes the dogma or the debate of technically BCLCC, although very limited BCLCC, is local regional versus systemic, or...
So I would say there's no right answer, right? No one knows the right answer here. And so a lot of it becomes experience, opinion, your institutional bias as well, whether there's a trial open, where we have trials and you guys have trials. So, if this patient fit into a clinical trial, they might get funneled that way as well.
The loudest voice at tumor board.
The loudest voice at tumor board, right? Yeah, so exactly. So let's just say trial was not available, or the patient's not, interested. Again, this is more personal opinion. This technically and anatomically seems like it would be a relatively straightforward radioembolization, where our response rates, even for segmental PVT, are the same as the response rates for non-PVT, right? They're basically identical. When are they not identical? When we start getting VP3 and VP4, when they're going down to the main portal vein, that's where we start to fall off. So I would argue that if we can do a radioembolization and we can show a complete response, then it becomes plus or minus, do you add systemic therapy? And the other option is to start with systemic therapy first and then go work backwards, work the other way.
Medical oncology's opinion?
I think that's a great summary. As you mentioned, if we're following guidelines, this patient has TIV, their BCLCC, those patients have phase 3 evidence that systemic therapy can improve outcomes. So I think starting them on a systemic immunotherapy regimen is certainly reasonable. The other point I would make here, though, is I think for a patient that can have some shared decision-making, this is a good time to think about what makes the most sense for that person. Do they live in a camper van in the desert and can come out for one treatment? Then let's do a tear. Is their daughter an immunologist and is pushing you towards immunotherapy? Sure, give immunotherapy a try. But when we don't have a right answer, I think that either sequence makes sense to try. I don't think you lose much by starting with systemic therapy here. If their cancer blossoms throughout all areas of the liver, I don't it's declared itself. Moving forward with local regional therapy doesn't make sense there. But if they respond well and we want to consider tear in the future, I think that that's certainly a consideration.
For a variety of different reasons, unrelated to the anatomics, but more of patient selection, we started STRIDE, and he had a partial response within the tumor after, I think, 1 or 2 cycles. We repeated imaging, and now there's a small little dot right next to the tumor that's new. Had our best radiologist confirm it's definitely new. So we chose to then move to local regional therapy, where we did a tear. And when we did the angiogram for the tear, we actually saw additional 2 or 3 small little tumors, to your point earlier, kind of in that same segment 3 area, just a little bit more downstream from where the tumor was. And his tumor markers were also rising at this point. So now we've done that, and this is kind of our response. We have non-progressing. This is, kind of a typical tear response where, maybe you see the small little black dot where that little nodule used to be, but there's a lot of parenchymal changes, again, trying to cover all the miliary metastases that maybe we see or don't see from this tumor in vein. And he's continuing on immunotherapy. And so the question, which we kind of alluded to before, is this guy does have particularly bad portal hypertension and would likely benefit from a transplant medically. When do we start considering that? How long would we feel comfortable on immunotherapy without progression?
That's the magic question, right? And we tend to, pick arbitrary time frames, somewhat arbitrary, 6 months. What's the difference between 6 months and 9 months, right? Or 9 months, yeah. So, yeah, I think you get out 6 months from, from the, point where you are your baseline, and if you show stability, then you start entertaining that question whether transplant's appropriate. But I think you need at least 6 months of stability. I don't know how Adam feels about it.
I think I would quote what Heather said earlier, a good long time, which I probably would favor more like a year or two just to kind of see how things move forward. But you're right, there is absolutely no data or right answer to tell us what to do here. And we do have to kind of use our best judgment. But again, as I mentioned earlier, I'm always just a little bit cautious about moving to transplant too soon on a person responding to immunotherapy, because I don't want to burn bridges for the future and then lose that opportunity if they're to have a post-transplant recurrence. I mean, at the end of the day, this person did present with TIV. We know those patients are higher risk, and we have to be mindful of that.
And Adam, in a case like this, you stick with Stride, even though they had a recurrence on the regimen because it was a small, so you would keep going with that before transitioning.
Would.
What would prompt you to say, we got to go to,
If you need it, or
yeah.
Obviously, extrahepatic spread or kind of more diffuse involvement throughout the liver, clear progression that's, not subtle. I would also argue or push back a bit on, was this progression, happened very early on immunotherapy? Could this have been pseudoprogression, something that was already there that was starting to flare a bit with immunotherapy? And maybe we've just used a thoughtful multimodal approach to get the disease all under control.
What if it popped up on the other side of the liver?
You could still make the argument it's tiny. It's not like it was a 5-centimeter tumor that appeared with aggressive biology.
I think these are the questions that we're going to be asking ourselves for many years to come, especially as all these technologies get better.